Well, welcome back. In this second session devoted to obstructive diseases of the lung, we're going to be looking at asthma. In the first, you'll recall, we looked at COPD in some detail, and of course these diseases are very different, these two diseases. For example, obstructive COPD is largely preventable if we can get rid of this scourge of smoking. It mainly occurs in middle-aged to older people, whereas asthma occurs at all ages, but particularly in young people. And interestingly, the amount of asthma appears to be increasing, particularly in well-developed countries, and we don't know why this is. So let's start with a definition of asthma here. It's a disease characterized by increased responsiveness of the airways to various stimuli, manifested by inflammation and widespread narrowing of the airways that changes in severity either spontaneously or as a result of treatment. Incidentally, it's interesting that for a very long time people have recognized the increased responsiveness of the airways, but the role of inflammation is a more recent development, and we'll say more about that. Let's look at some of the clinical features of asthma. Now, it often begins in children, but it can occur at any age. Sometimes, but not always, there's a specific allergen that can be found. For example, ragweed, or an animal such as a cat, or pollens, particularly serious in the spring, for example. And there may be other features of atopy, for example, allergic rhinitis, eczema, something like that. So there is an allergic form of asthma, but there is also a non-allergic form, and the reasons for that are not so clear. As we've seen, there's a general hyperreactivity of the airways, so that they respond to factors other than allergens, such as smoke. In fact, secondhand smoke is a serious problem with some people, cigarette smoke. Cold air is another factor, exercise also, aspirin. All these things can cause hyperreactivity of the airways. This can be tested using methacholine, which induces spasm, induces bronchoconstriction, and is a useful way of, is useful in the diagnosis of the condition. During an attack, the patient is usually anxious, has a lot of anxiety, and in fact psychological factors are important in asthma. Sometimes people who get into a situation where they are challenged psychologically will develop an asthma attack. There's a condition known as status asthmaticus, which can continue for many hours. Now, a normal attack of asthma is relatively short-lived, a few minutes to an hour or so. But in status asthmaticus, the condition may continue for 24 hours, a couple of days. The patient becomes exhausted. The airways are unresponsive to treatment. It's a serious condition and requires aggressive therapy. Now let's look at some of the pathological changes in the airways, because that's where most of the action is. And first of all, on the left here, we've got a drawing of a normal airway with a nice large lumen, as you can see. Here's the airway epithelium. We've got a relatively small amount of airway smooth muscle around it. The airway wall itself is not very thick. We have mucus glands in the airway, and we have some cartilage as well. And look at the changes that we see with asthma. Well, the first thing we note is that the caliber of the airway is greatly decreased. And I suppose in this particular instance with the mucus here, we may have it reduced, well certainly it's reduced to more than 1/2 of its normal diameter. Now you'll recall when we discussed airway resistance in the session on pulmonary mechanics that we referred to Poiseuille's law, and that refers to laminar flow in airways. And Poiseuille's law says that if you reduce the caliber of an airway to 1/2, you increase its resistance some 16 times. There's a radius to the 4th power. So you can see that in an instance like this, where we have a nice large airway like this, which is reduced in its caliber to certainly more than 1/2 here, there's a tremendous increase in airway resistance. Now in this airway you can see a small amount of mucus, and there is mucus produced in asthma, nothing like as much as in chronic bronchitis, but the mucus tends to be viscid, sticky, difficult to move, and it can completely plug the airways, as we shall see. We then get to the cells lining the epithelium here, cells lining the airway, and then we get a big increase in the thickness of the airway itself. See, it's greatly increased in thickness, and that has to do in part to the inflammatory changes and the edema of the airway walls. There's also an increase in the thickness of the smooth muscle. You get hypertrophied bronchial smooth muscle here, which contracts. You can also see the increase in the mucus glands in the airways, a little bit like the situation in bronchitis, where you recall that one of the most important pathological features is the hypertrophy of the bronchial mucus glands. And then we can see, of course, the cartilage here, which is unchanged. So dramatic changes in the appearance of the airways in asthma, leading to a striking reduction in the caliber of the lumen, and that of course is responsible for the big increase in airway resistance. Now, as I said, sometimes the airways can be completely obstructed by mucus, and here's a very nice light micrograph showing this with an airway probably cut transversely here, which makes it this rather strange shape, and you can see the mucus within it. You can also see, incidentally, some remodeling of the basement membranes here. This is called reticular basement membrane, and it's a form of remodeling that occurs in asthma. You can also imagine that this smooth muscle here is hypertrophied and contracting, and that's giving us this contracted airway completely obstructed by mucus. Patients who die in status asthmaticus at autopsy show many of their airways completely obstructed by mucus. As I said, the mucus in asthma is difficult to move and difficult to cough up. Now let's talk about the pathogenesis of asthma. And we've already referred to the airway hyperresponsiveness, not only in response to the allergen, but response to cold, exercise, smoke, whatever. In addition, we've mentioned the airway inflammation, which, as I said, has only been emphasized in the last 15 or 20 years, but it's a very important feature of asthma. Often, as we said, there's an allergic basis, but not always. There is both allergic asthma and non-allergic asthma. Now, what's responsible for the increase in the amount of asthma we're seeing? And that's particularly the case in well-developed countries. Well, I don't think anybody knows, but an interesting hypothesis is the hygiene hypothesis. And this has to do with the fact that young people today are not exposed to the potential allergens that many of us were exposed to when we grew up. And if I can just give you an example with myself, my mother's people came from a farm, and I used to go down to the farm quite frequently in the holidays and so on. And there I was closely surrounded by sheep and horses and cows, and they were defecating everywhere. So I was certainly exposed to all sorts of factors on a farm. If you go and visit my grandchildren who live in a very nice house, you've got to take your shoes off before you get into the house. So it's a very different environment, And one of the hypotheses is that the immunological system developed at an early stage in response to these factors, dirt and fecal factors and so on. And today this doesn't happen. Whether that's true or not, I don't know, but it certainly fits with the fact that in well-developed countries, the asthma is increasing tremendously. But there are also pollutants that are blamed, and some people think that engine exhaust, for example, particularly perhaps diesel engine exhaust, is a factor. There's also a genetic component to asthma, although it's not a simple series of events. It's a complicated genetic thing, but some people think that may well be a factor. Now let's look at a scheme for the pathogenesis of asthma. In this particular scheme, there's an antigen here, some kind, and the combination with lymph cells, and mast cells are stimulated. Now, it used to be thought that mast cells were particularly important in the generation of the asthma attack, but now a lot of people think that other cells are important. For example, eosinophils may be very important, and other cells as well, leukocytes as well, so that people don't concentrate quite so much on the mast cell now as they did. Whatever cell it is, it releases mediators, or is responsible for the development of mediators, and these can be of a big variety here. And these mediators have two separate effects. One is that they induce inflammation, and in fact, for example, in the capillary, they will increase permeability, they will cause edema of the wall of the airway, for example, and other inflammatory changes as well. And in addition, they will affect the airway smooth muscle by reducing the concentration of adenyl cyclase, reducing the concentration of cyclic AMP, and that leads to contraction of airway smooth muscle. So let's go on and look at the possible inflammatory mediators. Now, there's a whole variety of these, and I should emphasize that research on the mechanism of asthma is a very active area, and things are changing all the time. But here are some of the inflammatory mediators that have been recognized. For example, there are cytokines associated with T helper cells. These include a variety of interleukins, as you can see here. There are the arachidonic acid metabolites, including leukotrienes and prostaglandins. Histamine has always been thought to be an important factor in asthma, and that's one reason why the mast cell was implicated so much early on, and also platelet activating factor. So there's a great variety of inflammatory mediators, and these are being studied all the time and being added to. Now let me move from the causes of asthma, from the pathogenesis of asthma, to the bronchoactive drugs, because these are of major importance in the treatment, the management of patients with asthma. And there are two major classes of drugs, the beta-adrenergic agonists and the inhaled corticosteroids. And they're by far the most important medications. I'll say a few words about the supplementary drugs that are used, including new therapies, but the major classes are the beta-adrenergic agonists and the inhaled corticosteroids. Let's look at the mechanism of the beta-adrenergic agonists. Now, there are two kinds of beta receptors. There are the beta-1 receptors in the heart, which increase the heart rate and the strength of contraction of the myocardium. And there are beta-2 receptors that exist in the bronchi, also blood vessels, and the uterus. And stimulation of these beta-2 receptors results in the relaxation of smooth muscle. Now, I can remember when asthma was treated by drugs that were both beta-1 and beta-2 receptor agonists, but this has changed now, and only selective beta-2 receptor agonists are exclusively used now in asthma. There are quite a number of those available, and they have the advantage of just stimulating the beta-2 receptors, and the beta-1 receptors not affected or very little. These stimulation of the beta-2 agonist receptors increases the activity of adenyl cyclase, which raises the concentration of cyclic AMP in smooth muscle. And so they reverse the changes that occur as a result of the factors released by cells which reduce adenyl cyclase and reduce the concentration of cyclic AMP. That's one of their actions, but the other one is that they reduce airway inflammation. And it's these two factors that are important in the management, the treatment of asthma. And we saw this here in the previous slide, you recall. We made the point that the mediators, and there are a whole variety of these now, this is a rather old list, but a much larger variety now of mediators with two quite separate actions. One is to reduce the inflammatory changes, including the permeability of the capillaries, and the other is to reduce the contraction of the bronchial smooth muscle. Now, the beta-adrenergic agonists have different durations of action, and this is important in the management of asthma. There are long-acting forms, and these include formoterol, salmeterol, and they are particularly useful in the prolonged management of patients with asthma. They are usually used in conjunction with inhaled corticosteroids. But there are shorter acting forms such as metoprolol and albuterol, and they are now largely reserved for rescue use. Whatever beta-adrenergic agonist is being used, it should be delivered by a metered dose inhaler, and patients should be taught to use these inhalers appropriately by demonstrating the way to do that. So now, in addition to the beta-adrenergic agonists, we have the inhaled corticosteroids, of which there are now a large number. And these have two separate actions. On the one hand, they inhibit the inflammatory and immune response, and on the other hand, they enhance the beta-2 receptor expression or function. And they are extremely valuable. Most asthmatics benefit from these medications, and in fact some physicians feel that all asthmatics should be given inhaled corticosteroids. However, there are people who are less aggressive, and a common guideline is only to use inhaled corticosteroids in patients who need beta agonists more than twice a week. So that's one of the guidelines that's frequently used, although, as I say, some physicians would like to use corticosteroids in all patients with asthma. Inhaled corticosteroids have minimal systemic absorption, so fortunately we don't see the more extensive effects of corticosteroids. There are supplementary bronchoactive drugs. One class, and I'm not going to say a great deal about them, one class are the methylxanthines, including theophylline and aminophylline. The mode of action of these is not absolutely clear, but they've been used for many years as adjuncts in the treatment of asthma. Sometimes anticholinergics are suggested because there's some evidence that the parasympathetic nervous system plays a role in the bronchoconstriction of asthma. But generally speaking, those are not very popular, not very useful. It's interesting that anticholinergics are sometimes used in patients with chronic bronchitis who have a degree of bronchoconstriction that can be relieved. There are also drugs, cromolyn and netocromil. These have been used in the past, they're not much used at the present time. And interestingly, there are a number of newer therapies that are coming online. one of the leukotriene receptor antagonists, and another, omalizumab, which is a monoclonal antibody to IgE. It's an expensive drug, but it's sometimes used in patients who are refractory to beta agonists and also to inhaled corticosteroids. Let's turn to to pulmonary function in asthma. And of course, the main problem with asthma is the change in ventilatory capacity and mechanics. There are also changes in gas exchange that I'll talk about briefly, but it's the mechanical function, the airway obstruction, which is responsible for most of the distress and the limited activity in asthma. And of course, that can be demonstrated using a forced expiration. And in fact, the forced expiration, the measurement of the FEV and the FVC, are critically important in asthma, particularly in the assessment of the value of bronchodilator drugs. In obstructive disease, as we've seen many times, the FEV is reduced, and that of course is because of the airway obstruction. The patient cannot exhale the air as rapidly as a normal subject can do. But the FVC, the forced vital capacity, is also reduced, and that's because the airways that are diseased, of course, they have increased constriction because of the increased activity of bronchial smooth muscle. They are edematous, and because of their disease, they tend to close early towards the end of expiration, and that's responsible for the reduced forced vital capacity. Sometimes the effects of bronchodilators are very dramatic, and this is a particularly dramatic example, but you can see that the forced expiratory volume, although it was not actually calculated, the volume exhaled in the first second is enormously increased, and also the forced vital capacity is increased because these diseased airways did not close so early in the expiration. So the measurement of the effects of bronchodilators on the airways using the FEV, FVC, very important in asthma, and the disease is followed all the time by doing measurements of forced expirations. Of course, very easy to do and very informative. The expiratory flow volume curves are also affected in asthma as they are in other types of obstructive disease. Here's the normal pattern here. And in obstructive disease, first of all, typically you start at a high lung volume, and I should say here that the flow volume curves are plotted on in a way that shows total lung volume, but this is not normally available. But it's instructive because you can see that the patient starts at a high lung volume and finishes at a high lung volume, and of course the flow rates are very much lower, particularly during most of the expiration. One of the differences between asthma and COPD is that in COPD you often get a shape like this, where the flow rate decreases in the middle of expiration here, but in asthma you don't get this change in shape of the curve. Now, lung volumes are greatly increased in asthma. Both the FRC, the functional residual capacity, and the total lung capacity are increased during an attack. And it's important that lung volumes do increase. One way of looking at this is that when lung volumes increase, you increase the radial traction on the airways and you tend to reduce their resistance. Of course, the resistance is increased by the disease process, but one way of looking at this is that if lung volume didn't increase, the increase in airway resistance would be so great that probably it would not be compatible with life. So lung volumes increase in asthma. Also, interestingly, lung compliance increases, but the reason for that is not known. There's nothing wrong basically with the lung parenchyma in asthma. If you look at the histology of the alveolar tissue, there's nothing particular to be seen. So it's not at all clear why the lung compliance is increased. It's been suggested that this may have to do with changes in surface tension, although I don't know that that's the complete explanation there is understood. As we've said, the residual volume is raised because the diseased airways close prematurely in expiration, and that can be explained by both the inflammation and the hypertrophy of the bronchial smooth muscle. Another measurement that's interesting is that the helium dilution measurement of lung volume is usually much less than that measured with the body box, and this is presumably partly because many of the small airways are completely obstructed by mucus, as we saw in one of the earlier images, but it's also probably caused by the fact that there is so much uneven ventilation that the patient does not distribute the helium uniformly throughout the lung in the time available for the measurement, and so we don't see the whole of the lung as a result. Here are some pressure volume curves showing that in asthma, as I mentioned, the compliance is increased. The volume for a given transpulmonary pressure, and here we're looking at volume against transpulmonary pressure, the volume for a given transpulmonary pressure is greater than normal, shown by the red line here, and the slope of the line is somewhat increased. Not as much as in emphysema, but nevertheless there is apparently an increased compliance in asthma. As I said, the causes for that are not clearly understood. And you'll notice that in interstitial fibrosis, there's a tremendous reduction in compliance. Flow rates, of course, are reduced in asthma, and one way of measuring those is a forced expiratory flow, which clearly indicates an increase in airway resistance. And the airway resistance can be measured in a body box and shown to be increased. As far as we know, airways of all sizes are constricted. Certainly very small airways are constricted, and if you look at the larger airways, the medium-sized airways, during bronchoscopy, you can see that resistance also occurs there. Now let's look at gas exchange in asthma, and it's certainly abnormal, as you would expect from the airway problems and therefore the uneven distribution of ventilation perfusion inequality. But the changes in gas exchange are not nearly so important as the mechanical changes, the changes in airway resistance, which are responsible for the distress and the reduction in exercise tolerance, for example, of these patients. However, there is clearly a marked inequality of ventilation, which can be measured with the single breath nitrogen test, which we referred to earlier. You recall that in that test, the subject takes a vital capacity breath of oxygen and then exhales slowly, and we record the exhaled nitrogen concentration against lung volume. And in normal subjects, the alveolar plateau, as it's called, is almost flat. Always slopes a bit, but the slope is quite small. But in a patient with asthma, the slope will be substantially increased. And you can measure the degree of uneven ventilation by looking at by measuring the slope. So there's certainly a lot of uneven ventilation in asthma, and that can also be shown by topographically by using radioactive materials, radioactive gases, inhaled radioactive aerosols. You can see areas of the lung that are poorly ventilated, as you would expect. There's also ventilation perfusion inequality in asthma. The arterial PO2 is always reduced, although this is generally not very severe. And it's interesting that the arterial PCO2 in asthma is usually normal. In fact, it might be slightly low under some conditions. If there is an increase in the PCO2, the arterial PCO2, and this sometimes occurs in status asthmaticus, this is an ominous sign and indicates the need for very vigorous therapy. You may say, well, why is the arterial PCO2 normal? We know that ventilation perfusion inequality interferes with the transfer of CO2, but as we've said in connection with COPD, many patients with COPD have a normal arterial PCO2, and that's because the body is extremely, quotes, reluctant to see the CO2 rise because that affects the pH falls, that affects the function of enzymes, affects configuration of proteins, affects the central nervous system. So the body tries very hard to keep the CO2 normal, and that can be done in spite of the ventilation perfusion inequality by raising the ventilation to the alveoli. And that's what's normally done in most patients with asthma. They have an increased ventilation to the alveoli in spite of the fact that they have an increased airway resistance, and this keeps the PCO2 usually normal. Now, you can look at the distribution of ventilation perfusion inequality in asthma, and I'm going to show you a couple of examples here. Actually, these are measurements made in our laboratory a number of years ago, and this particular patient was a young patient with asthma. It wasn't all that severe. As you can see, his arterial PO2 was 81, probably should have been in the mid-90s somewhere. So it was reduced, but not dramatically reduced. And this patient, at the time of the measurement, did not feel as though he was particularly diseased at all. His asthma is not serious, although I should say that at this time, probably the management of asthma was not as sophisticated and as aggressive as it is today. And what's interesting is that the distribution of ventilation perfusion ratios is clearly very abnormal, as you can see. There's one mode where the ventilation and blood flow are situated close to the normal value, ventilation perfusion value of 1, but you can see a substantial amount of blood flow going to units with low ventilation perfusion ratios. And presumably those are lung units behind highly obstructed airways, or perhaps completely obstructed airways obstructed by mucus. It's very interesting that in this patient there was no shunt, so that in spite of this large amount of blood flow to poorly ventilated units, there was no shunt. And I think this suggests that the shunt may have been due to collateral ventilation. And just to remind you, there are several mechanisms of uneven ventilation. There's the normal mechanism that we usually think of, where an airway is partly obstructed by mucus or whatever, and therefore ventilation is uneven, and that's called parallel inequality. There's a mechanism called series inequality, where the diffusion of the gas along the airway is compromised, and a possible example of that is centri-acinar emphysema, where the center of the acinus is greatly enlarged, and you may well have some series inequality of ventilation as a result. And finally, there's the mechanism known as collateral ventilation, where gas reaches the alveoli, but not through the usual channels, but through connections between small airways, or even conceivably connections between alveoli under some conditions. But there are collateral channels, and that may be the reason why there was no shunt in that patient with asthma. Now, that patient was given a bronchodilator, and a very interesting change in the distribution of ventilation perfusion ratios occurred. Again, you can see the normal mode of distribution here, but look, there was a big increase in the amount of blood flow going to lung units with low ventilation perfusion ratios. Again, no shunt, as you can see. Consistent with this increase in blood flow to poorly ventilated areas, the PO2 fell from its former value of 81 to 70. And what's responsible for this increase in blood flow to poorly ventilated areas is not absolutely clear, but possibly the blood flow is affected by the mediators that are constricting the airways, and they also constrict the blood vessels. When the asthma is treated with a bronchodilator, the function is not only to release the bronchoconstriction, but to release the vasoconstriction to some extent, and that's the reason why the blood flow increases to these poorly ventilated areas. Now, this fall in arterial PO2, a relatively small fall in arterial PO2 when a patient is given a bronchodilator, is seen often. Does that mean that we should limit the use of bronchodilators in any way? Not at all. These changes in gas exchange are interesting but relatively unimportant, and it's far more important that we treat the bronchoconstriction, which is responsible for the distress of the patient and responsible for most of the physiological changes. Now I'm going to change gear and finish with a brief discussion of localized airway obstruction. We dealt with COPD in the first lecture on airway obstructive lung disease, and here we've dealt with asthma, not such an extensive topic to discuss, and it gives us an opportunity to talk about localized airway obstruction. And we can divide that into tracheal obstruction and bronchial obstruction. Now, tracheal obstruction has many causes. One of them is an inhaled foreign body. In fact, an important cause is if somebody during a meal inhales a piece of meat, for example, gets stuck, then it's important that that be removed. And one way of doing that, I'm sure you know, is using the Heimlich procedure. Stand behind the patient, put your arms around the lower part of the chest, actually below the xiphoid and the upper part of the abdomen, and pull hard, and with a bit of luck you can remove the foreign body. So that's one example of tracheal obstruction, a potentially lethal condition. Another is compression of the trachea from outside. Enlarged lymph glands will often do this, or enlargement of the thyroid gland can do it under some conditions. Or of course there may be a neoplasm either in or outside the trachea which obstructs it. There can also be stenosis of the trachea after tracheostomy, or sometimes after the use of an endotracheal tube. We don't see this so much now, but in the good old days, endotracheal tubes used to have a cuff which was very stiff and would damage the airway wall, and after the tracheostomy tube had been removed, you could get some stenosis of the trachea. Now, if tracheal obstruction is very marked, you can get a stridor, a loud wheeze, an inspiratory and expiratory stridor, because the thing about tracheal obstruction is that not only do you get obstruction during expiration, which is what happens in COPD particularly, but there's also inspiratory obstruction as well. And if the obstruction is severe enough, you can develop a hypoxemia and CO2 retention. Occasionally a patient will come in with some tracheal obstruction which is not diagnosed, or it's misdiagnosed, and he's given bronchodilators as a test of airway obstruction, and there's no response. And that should alert somebody to the fact that tracheal obstruction should be looked at. And one way of testing for tracheal obstruction is to do flow volume curves, which are shown here. On the left we can see the normal both expiratory and inspiratory flow volume curve, and we can see the curve for COPD with its scooping out here, which is characteristic of COPD, and the inspiratory curve is also affected, though not as much as the expiratory curve. But when you do this with tracheal obstruction, typically you get a flattening of both the expiratory and the inspiratory flow volume curves. Particularly the inspiratory one is very interesting, because the only situation, I believe, where you can get that is tracheal obstruction. So that's an important test. Now let's turn to bronchial obstruction. And a bronchus, a major bronchus, large bronchus, medium-sized bronchus, can be obstructed in various ways. In young children, toddlers, an inhaled foreign body such as a peanut is a common cause. And incidentally, the peanut will very likely go into the right main bronchus as opposed to the left, because the left makes a sharper angle with the trachea. Another important cause of bronchial obstruction is aspiration following surgery. When the patient is unable to cough, The cough reflex is dulled, or patient has pain, not able to cough, and aspiration can cause obstruction. Retained secretions in severe bronchitis can do this. Of course, you can have a neoplasm in a bronchus, or the bronchus can be compressed from outside by enlarged lymph glands, or indeed by a neoplasm outside. And occasionally an endotracheal tube is misplaced. It's pushed down beyond the carina and ends up in the right or left main bronchus, usually the right main bronchus perhaps. Now, an important feature of bronchial obstruction is that it can cause absorption atelectasis. And I want to finish by just telling you about the mechanism of that. The mechanism depends to some extent on the composition of the inspired gas. And if you're breathing an oxygen mixture, of course we don't often breathe pure oxygen, but if you're breathing an increased oxygen mixture, that's quite common post-operatively, because very often post-operatively patients are being treated, they're hypoxemic and they're being given an enriched oxygen mixture to breathe. And you can see that in this case with pure oxygen, the sum of the partial pressures in the alveolus is enormously greater than the sum of the partial pressures in the mixed venous blood coming into the lung. And that has to do basically with the shape of the oxygen dissociation curve, that the PO2 can be extremely high, but the oxygen concentration is not enormously increased. When the oxygen is removed from the blood, as the blood passes through the peripheral capillaries, the PO2, the oxygen is removed, the oxygen concentration is decreased, and because of the shape of the dissociation curve, the PO2 falls to a very low value, in this case about 55. So there's an enormous difference between the alveolar PO2 and the PO2 in the mixed venous blood. Because the sum of the partial pressures in the alveolar gas exceeds that in the blood, gas will inevitably move out of the alveoli and you will eventually get atelectasis. And this can be quite fast if the oxygen concentration is high. Now, this also occurs during air breathing, but much slower. During air breathing, as in this particular example here, the sum of the partial pressures in the alveolar gas is about 760 normal, but the sum in the mixed venous blood is substantially less. And it's less because, again, of the slope of the dissociation curve. You see, there's a big difference between the PO2 in the alveolar gas, 100 here, as opposed to the mixed venous blood, only 40 here. As a result, inevitably, the gases move out of the alveolar space into the blood. Now, this is a much slower event, and actually it can be shown, it's rather a complicated process actually, but it can be shown that the rate at which the gas moves out has a lot to do with the nitrogen concentration. So in this particular instance where we were talking about pure oxygen, there's no nitrogen in the alveoli. The loss rate is very, very fast. But even small amounts of nitrogen can slow the rate down, and the rate is very much slower in the case of air breathing. Sometimes people talk about nitrogen as being a splint, as it were, which slows the rate of removal of the gas. Now, this is an important factor in bronchial obstruction, of course. What you can get is atelectasis of a region of the lung because an airway is obstructed. And that's one reason why we should try and remove secretions if we can. Sometimes this is done through the endobronchial tube, trying to remove secretions. But this phenomenon is also very important generally because it is the reason why, for example, a spontaneous pneumothorax is gradually removed by the blood. In a spontaneous pneumothorax, the same thing happens. The sum of the partial pressures in the pneumothorax gas exceed that in the mixed venous blood, and the pneumothorax is absorbed. The same is true if, for example, inadvertently during intravenous attempts at intravenous therapy, somebody introduces air under the skin. That air is removed by the same technique. Okay, so that's all I'm going to say about obstructive diseases of the lung. The most important topic perhaps was COPD. And again, if I'm not boring you, let me just say that it's so important that we try and get rid of smoking, because that is the main factor responsible for COPD. We then went on to look at asthma. Again, an extremely important disease, quite different from COPD, of course, but an extremely important disease, and the amount of asthma apparently is increasing. It's becoming a serious problem. It's sometimes not easy to treat, not easy to control, and the reasons for the increase is not clear. And then we finished with a brief discussion of airway obstruction, of localized obstruction of the airways, which is an important topic, particularly in the post-operative environment. And so I hope to see you next time.